Well, I guess it starts from when I wanted to probably start doing nursing in general. I was at school, I didn't know what I wanted to do, went off to do I went to do hairdressing because my friend was doing it, so I thought that was just something to do. I didn't really have any aspirations, I have to say, to be a nurse. It wasn't something I always thought about. Then I then got a job doing sort of meals and drinks at a local hospital, and it was kind of really from there that I got this bug, I think, of, oh, this is really interesting, but of course I didn't think it would be something I'd be able to do. I had to go back to college in the evenings and sort of get my grades up if I did want to go and do my nurse training. But what really supported me, I think, was being approached by different nurses, them being great role models, I have to say, and really supporting me in this whole process of, okay, we think you've got something, and then kind of helping me to organise my time better, do my training. And then I then went off to university in London in '97 and did my training, and then did my training for 3 years, qualified in 2000, and my first job was on a neurology ward on an acute stroke unit. So there was lots of focus on rehab and the importance of it there. And I just found the patient group really fascinating, I have to say, really interesting. I think maybe because my grandmother had a stroke when I was a teenager, so maybe I was thinking did I want to make it better for someone else? Or was it just I was very curious about how the brain works and how amazing it can be when people can regain function after having, such a period of disability and illness. I think it was the fascination that we don't know anything or much about it, I suppose, that's intrigued me. I think mostly it's because it's exciting, it's rewarding, it's hugely challenging, especially being a lone practitioner. But I'm the one continuous link for our patients who come through the trust. So they'll come here in their acute phase, whether it be intensive care or onto the neurosciences ward. And then I will be linking in with them, their families, and the staff as well, just looking at any problems that they might be having throughout the whole admission, sort of trying to troubleshoot, sort of linking in with the wider MDT. So certainly looking at their rehab options when they've arrived, even, looking at their address and thinking what's available in that area. Being able to be that education focus as well with staff and with patients, and reassuring them throughout their admission. And then luckily I get to see patients as well in clinic because I work for 12 neurosurgeons and 4 neuroradiologists, so I follow up all of their patients who have come through the trust. So it's all nurse-led clinics. So I get to see people, or I did get to see people pre-COVID. I get to see how they've done, and it's so rewarding when they walk into clinic and the last time you saw them they may have been either in a wheelchair or using some other form of aid to help with their ability, or communication may have been a problem for them, or the thought processing, that side of things. But to see them and to talk to them and see how they've progressed that's hugely rewarding, I think, in itself. And you just play a small part for sure, but it's really, really good to see. So when I first started at the trust quite a few years ago, I've only been in this role since sort of late 2015, but I worked on the neuro-intensive care before this, and I had a interest in subarachnoid hemorrhage patients there because I was helping out with some research into this patient group. And I got talking to patients when they came back for some of their follow-up, and found there was a really big gap when they left the hospital. They felt like they'd literally been abandoned and they had no one to talk to about their symptoms that they might be having, or, what's normal, what do I expect? So I kind of did a business case to get some stamps. So I was told you needed to do a business case for everything in those days. So I got some stamps, wrote lots of letters to ex-patients, and then asked them if they would be interested in a meeting, like a focus group, to meet other patients and relatives. Got the feedback. They said yes. they did want it. So I booked a room with a friend, we made some cakes, we got some tea and coffee, and that was really it. That was the birth of the Subarachnoid Hemorrhage Focus Group, and that was in 2013. And from there, it's gone from strength to strength. We have got a website now, which was designed by a ex-patient who kindly did that for us. It's now been taken over by the OUH, so it's got an NHS address. We've got a closed Facebook group as well, so that people can chat 24/7, because our meetings are only like every sort of 3 to 4 months, and it can be quite difficult, a bit of a gap really. And we were fortunate enough to win the Nursing Times Awards in 2015 for the innovation, which is really fantastic for the group. Really good to celebrate, all of their help, because we wouldn't have the group unless it was for them and their ideas. And they've, as a team, as the group, they've really helped shape how we do things as well in the trust. So they've helped with designing some patient information booklets. They've also reviewing a non-aneurysmal subarachnoid hemorrhage booklet for me at the moment, which is great. So they're really key, I think, in using them to help shape what they want for their service in the future. So that's something we're really proud of. And also we've just started Rehab Champions as well on the ward. So this is just for people, so either nurses or health care support workers, or anybody who's interested really in just going that extra mile for patients. It doesn't cost anything. It's literally about talking to patients, helping with their rehab pathway, whether it be just taking them for a walk, playing a game with them, having a conversation, helping them with their eating and drinking. All of those things can really help develop somebody, I think, in their sort of potential, just, that interaction. It can be a difficult patient group at times, purely because not through their own fault, but with brain injury, it can be certainly quite challenging. It's frustrating when you think that you haven't done enough or you can't do enough for somebody when they've left the hospital because of those gaps that are there. And it's very much a postcode lottery, unfortunately, for rehab services. And it's such a shame that subarachnoid hemorrhage, even though it comes under the umbrella of stroke, it's not recognised by the stroke pathway, whether that's to do with sort of commissioning and money and things. But it's a real shame that we can't link patients onto that pathway, or have an ABI pathway, which is separate, so an acquired brain injury pathway where people can access the same as they would be able to for stroke services. And that's a huge challenge, because you feel like you've given them a lot when they're in hospital. You try and do early follow-up with the help of charities who kindly do an early follow-up for me, but you do feel that you failed people because of that. You're relying on people to bridge that gap, which it should be there already. It shouldn't be left to charities to just help out. Oh, just do it. It's great. It's really good. If they can play any part in just helping patients recover, I think they'll just get so much from it. It's very different to any type of nursing I've ever done, and I've only had 18 months away from doing neuro, and the draw just was too much. It got me back. But I think they will find it rewarding, really challenging. And the development opportunities are huge. My role came about through research, which was through the National Confidential Inquiry into Patient Outcome and Death. So there's lots of scope for many advanced roles as well. They can join the AMP pathway, which I'm on at the moment. So, and create roles for nurse-led services. It's definitely a Marmite kind of job, as I know I've said a few times. If people have watched these recordings, it's certainly a love or hate, but I definitely would love it. They can just the small things that they can really do. So we sort of talked about the Rehab Champions role, and I think, just being with that patient on the ward, talking to them, talking to their families, I think communication is really, really key. you know, like the World Health Organization talks about rehabilitation as an intervention that sort of is about preventing loss of function. It's about slowing the rate of that loss and, you know, improving, restoring, compensating for it. And nurses can do that, or healthcare support workers, you know, other members of the MDT can do that just by, you know, being the advocate, talking to them, you know, being supportive. You know, we talked before about having a quiet area on the ward, you know, where you can just go through information with patients and families. You know, there's lots of things that people can do, and it doesn't have to cost an awful lot.